So Bob emails, what do you say?
Yes.
All right, listener Ashley from Riverside, California, she wrote in and said, my therapist confessed that he likes me more than just a client. Bob grimaced.
Yeah.
My therapist confessed that he likes me more than just a client. I have had feelings of attraction towards him before. However, I did my research, and as a student pursuing psychology, I have decided that these feelings were perhaps temporary, and I should work on understanding transference. But about a month or two later, after he told me he likes me more of a client, he asked me out to dinner.
So were they having sessions that she was paying? She?
Yeah.
She was paying for these sessions, and as a result of these sessions, he asks her out for dinner. Does that just feel icky on many levels?
Yeah.
Ugh.
Yeah. Disgusting.
Yeah.
I thought it was for a session because his office allows therapists to meet outside, such as coffee shops, stores, etc. I went to dinner with him. He began to vent to me about his day as a therapist. He also said that in his 14 years of working, he had never felt this way, and he liked me a lot. He said I was sexy. He said I made him excited and nervous. He said how he wanted to hold my hand and take me out. He constantly asked if I was a virgin in previous sessions, which made me realize perhaps he had been grooming me.
Ew.
Goddamn. I am 20 years old, and he is 51.
Oh, super gross.
And divorced. And he has a 12-year-old daughter. For me, this situation was confusing because I liked him a lot, obviously, as he was my therapist and made me feel comfortable. However, I knew this was wrong, but I felt guilty. A few weeks after that incident, I told my parents. They said they would take care of it, and that was not to see him again. They said that they would take care of it, and that was that I was not supposed to see him again. I was not told what had happened to him. As of now, I still have no idea what his punishment was. I have recently reported him to the board, but I still feel confused. This situation led me to self-harm again, and my anxiety and depression has returned. I have found a new therapist, but after 4 months, I cannot understand why I cannot overcome this. Bob, what do you think?
I am so sorry. That just sucks, man. Life's hard enough, and somebody made your life harder. Hey, for what it's worth, though, it's not surprising to me that you're having a hard time with it still. Like, you really did have feelings, right? Some of that's probably just kind of ground up in your weirdo therapist projections or whatever. But I can't think of any human who'd gone through this who would just say, oh, yeah, okay, it's easy to trust again, and I'll start with a new therapist, and I'll feel great. You know, that's going to take some time. So I hope you'll talk about it, of course. And I hope that you will find a way to stop self-harming. It's bad for your body, and the chance of premature death is significantly increased when you're doing it, and you just deserve better than that.
Yeah. Yeah, a way of thinking about this that just occurred to me is that, you know, if you had a boss at a restaurant and they did this, that would be harassment and not cool. But, and I think often people will think of it that way, of just like someone that is doing something that's inappropriate. But a therapist-client relationship is more closer to a parent-child relationship in that it's one-directional. The therapist is there for the client. Obviously, there's a lot of ethics and training around these very issues that are very explicit, that you don't do this, and even if you have the impulse, you immediately look into it and get help, and obviously don't act on these things. But if your uncle or your dad asked you out romantically, I think we understand that that's not just inappropriate or sexual harassment. That is dismantling on such a deep level of your ability to trust and how you think of yourself and how betraying it is. You know, this individual, this therapist betrayed you on such a deep level. Like I said, it's not some friend of your ex-husband who asked you out. It's like, oh, yeah, it was kind of inappropriate. It's like, I don't really think that was the right venue, or he just couldn't help himself because he had a crush on me. This is way beyond that. And so, of course, you are having trouble getting over it. And the fact that, yeah, it does sound like he was grooming you.
Ew.
And he tricked you because you go to dinner with him not even knowing that this was a date. And you're at the date thinking it's a session, and halfway through the session, you're like, oh, he is on a date with me, and he didn't even tell me. And I'm only 20, and I had heard that people met with clients outside, so of course I thought this was just another session, and he's using me. He hasn't even asked me if I wanted to do this, right? He didn't say, by the way, I want to switch to a dating relationship. He just forged ahead. He told me I was sexy without asking if that's the kind of conversation that I wanted to have. He took me out to dinner without explicitly telling me that he was taking me out to dinner. Yeah, that it's being used. It's being treated like a sack of meat, and that obviously has an effect. That's why people like this should be run out of the profession, perhaps thrown in prison. Honestly, it's not fucking hard to keep it in your pants. That's what I say. Keep it in your goddamn. It's not hard.
It's not even hard to just ask yourself, what am I doing? If I find myself attracted to this client in this way, I know what this is. What the fuck am I doing to actually indulge it and think that it's real? It's just inane and ew.
And 51 and 20?
Well, age.
But you would think that would raise at least some flag for him.
Yeah, you'd think.
Like, well, at least, the client-therapist relationship is, more important to focus on, but you would additionally think the age difference.
I would.
Yeah, anyway. Let's take a break. We get back. Another email. What do you say?
Yes.
All right, we're back from the break. So let's cleanse the palate and do an OPP, but instead of me reading off the list, Bob, I'm going to ask you for a letter or a series of letters.
All right.
And you give it to me, and I'll type that into Patreon, and it'll give me the patrons who have those letters in their name, and I'll sort it by how long they've been a patron, and then we'll give a shout out. So
great. How about F? Let's just do F.
F. Why did you choose F?
I don't know.
You don't know.
Just came to mind.
Yeah, I like it. So I'm doing a sort by date. Oh my gosh! So we have Christy Forrester, who is a good friend of mine and a therapist and a former student and supervisee from years and years ago, but mainly a friend now. And she is at the top of the list. She has been a patron since 2016. And then we have Nick, who has been also a patron since 2016 from New York City. We have John, who has been a patron. I think he's from Norway, if I am reading that right. And then we have another friend of mine, Jill Forsberg. She's been a patron since 2018, and she is a colleague, therapist, and a professor at Antioch, and a former student of mine.
Wow, man.
And she is my brother's kid, Alina, who works for the podcast. Alina is going to Antioch and has Jill as their professor.
Oh, wow.
So small world all around. Then we got Frida, who has been a patron since 2018. And Frida's from God knows where. And the last person I'll mention here is Felix, who has been a patron since 2018 as well. And Felix is from God knows where. But his last name has an umlaut in it. So that makes me think German.
Probably German.
Right?
Yeah.
Are there umlauts other places besides, it's like Austria or
they
Holland?
Speak German. I'm not sure about the Dutch. Yeah.
Yeah.
Felix means luck.
Luck?
Yeah, that's what that word means.
Huh.
Isn't that cool?
Huh.
His name is Luck. I like that.
Oh, okay.
Yeah.
Anonymous patron and YouTube member, she wrote in and said, "Can you talk about skin picking? The more I look into it to try to help myself, the more I'm finding it affects a lot of people." Bob, do you know anything about skin picking?
I know no,
Yeah.
I don't know hardly anything.
Yeah, so I would just direct you to listen to the episode that I made about trichotillomania, which is hair pulling. It's a very, very similar thing. One could argue it's the exact same thing, but just manifests a little bit differently. There's some variation there, but it's considered to be a part of the body-focused repetitive behaviors. It's been called various things over the years. I think the skin picking is called trichotillomania or dermatillomania or something. And so, but all those words that are applied are kind of silly, like the various phobia words. Just say, fear of
clowns or whatever. We don't need
right. So you have skin picking, other people have hair pulling. There's other body-focused repetitive behaviors like a compulsion to pinch yourself or something. So the qualities of it is like any other kind of tic or compulsion, which is that it's compulsive. There are triggers. It causes distress. It's difficult to stop, that kind of thing. And, it can be managed. It can be treated. There's treatments for it. It can also just be lived with or there are ways of directing it in a way that doesn't cause problems, Like with hair pulling, you can have an interim phase or even an ongoing phase where instead of actually pulling your hair out, you will just kind of tug at your hair or comb your hair or just play with your hair or something. There's various different ways of managing it, but it obviously can stem from trauma. It can be a part of a broader trauma response. It also could just be on its own. But anyway, there could also be medications involved.
You mean that help treat it?
That, and there are medications that can cause it.
Oh, really?
Oh, yeah. There are people that will, for the very first time, develop tics and other kinds of compulsive behaviors as a result of, I think it's often the dopamine centric meds, because that has to do with motivation stuff. And, dopamine meds are involved in Parkinson's and a lot of other things that are commonly treated. So a side effect can be these kinds of things. You didn't know that?
I did not.
Yeah, I had a client many years ago who had, I think, Parkinson's and was taking a Parkinson's med and had developed sex addiction out of nowhere and was suddenly driving around town, shopping around for sex workers all night long. There's a local newspaper called The Stranger, and back then the back pages had a lot of advertisements for sex workers, and so he would call those compulsively all night long and claimed that he never actually hired anybody, and he was married and had kids and stuff. But yeah, for the first time now, his wife suspected that he had just been hiding it previous, but it looked like it was brand new. Because there's another thing that can happen is people can develop gambling addiction from these meds as well.
I did not know that.
Yeah. Yeah, just imagine, and it can be really rough because it can come on really strong and the individual has no coping mechanisms because they haven't struggled with it at all.
Overwhelmed by their impulse or whatever.
Yeah.
How common is that? Do you know? Like an impulse control problem as a result of the meds?
I think it's common enough that it's understood that it's a risk that should be discussed. And it can be so destructive that I think it's important for it to be highlighted.
Yeah.
Even if it is at like a 2% prevalence rate. But I don't know the percentage.
Okay.
My sense is that it's, 10, 20% or something.
Oof.
To some degree. Yeah. Anyway.
Yeah.
The next email, middle tier patron and paying YouTube member, Morgan, she says, "Hi, Kirk and Bob. You are both incredible, and I thank you endlessly for your vulnerability and compelling content. Not all superheroes wear capes," said some person who isn't me. Kirk, you have spoken about your research about the most difficult clinical moments for therapists. I ask because I recently had my most difficult clinical moment. I'm a psychologist and I've been practicing for 4 years. Okay, just chiming in. So I'm going to describe this is a bit long, but I find this description to be very rich and informative and interesting to me. So
I'm in.
I'm going to read it. You tell me what you think.
All right.
I had a moment this week where someone was expressing a terribly difficult experience, a traumatic incident from childhood. And I noticed myself shift, like I had settled into this intense alignment with my client. It felt like the most intense countertransference I've ever had. It was a feeling of despair and pain. And I felt this extreme need to pull myself away from the hurt, but I didn't. Instead, I held it and maintained contact with my client. It was sustained and heavy. When the session time was up, I felt the client cling to me as if they'd never been allowed to hold space in that way before. I got the sense that they didn't want to leave, and I understood why. I maintained this odd sense of heaviness until the door closed and they were gone. So just chiming in here, the client is telling about this traumatic incident from childhood. Sounds like a new kind of disclosure from this client. This psychologist is saying, I noticed a shift inside of me, like an intense alignment, a lot of transference. I started feeling despair and pain. I initially wanted to pull away from that because it hurt, but I didn't. I maintained contact. So I was holding on, and I was holding the pain. I was with the client and connected, but in a lot of pain, but also managing to remain a good listener and professional. So the client leaves, and she says, I fell apart when my client left. It was like I absorbed all of that hurt. I had and still have complicated feelings about it. I feel a bit terrified by it. I attribute that feeling to my own disorganized attachment, by the way. I feel anxiety about it. I attribute that to a fear that I will somehow disappoint this person or let them down or contribute to their existing attachment traumas. And I still feel heavy. And there's other feelings swimming around inside of me that I don't quite understand yet. It's the first time I've ever felt this level of intensity, and I don't really know what to do with it. What I do know is that I feel this intense privilege to have sat with this person and experienced this with them. And I have an intuitive belief that this is one of the moments that will make me a better therapist, a better partner, a better mom, a better friend, and a better human being. But I don't really know why or have words to explain. So just chiming in, Bob, what do you think so far?
Well, let's see. I love it in that you didn't block and you stayed in contact with your client and you went through whatever that awful thing was. And it sounds to me like in many ways just a really human response to somebody else's pain. It's lovely. It's tragic. And, I'm not saying I wish it had happened for the client or the story have the impact on the therapist, but it does, and it did. And so there it is. And so, that's part of the privilege that we sign up for. So that's really cool. And I who's your support? Like, do you have a mentor or a supervisor or a consultant, someone you can talk to about what's happening for you? Because there's something worth learning about yourself in it. Like you're afraid you're going to disappoint them. I mean, of all the things, you're going to disappoint them. That's interesting to me. I don't know what it means. And I wonder about that. And I wonder if maybe there's something worth exploring there for you, because maybe it has something to do with something in your therapy with your client. Or maybe it's just, as you say, just some idiosyncratic response that you're having to, bearing witness to whatever the thing was. But talk to someone about it. Like get some support and help, and at least don't be alone in it. And I would recommend someone clinically oriented, because talking to a friend about that, you're not going to get the kind of support that you could get. And talk to a clinician.
Mm-hmm. Yeah, and this is where free association comes in, because you are, so what I'll say is that, there are a couple of different angles here. One is that it's pretty simple in that there is some actual trauma that's being triggered in you, and you're not really quite aware of it, or you have touched on a new part of it or something. You mentioned disorganized attachment. So there was a closeness there that could be threatening, because disorganized attachment means that the closer you get, the more terrified you get, for good reasons when you're growing up. But also, it could just be getting close to the trauma. The childhood trauma that the client was talking about. It's not hard to imagine that you might have at least an analogous experience yourself. Even if you have been through a lot of recovery, it's not unusual to have that triggered in some way. But that's the more simple but valid angle when looking at these kinds of things. The other is another angle that doesn't usually get talked about, and it's much more in the psychoanalytic and psychodynamic tradition, which is that we can't, and especially in the contemporary version of it, is that you are experiencing a classic scenario that we're always feeling to some extent, sometimes more noticeable, like in situations like this, where we are experiencing the emotional field and we're only mildly consciously aware of it. And the things that we are conscious of, we're often interpreting in weird ways. And you can never just really be sure about what's going on inside of you, even if you didn't have any traumas. And the way you describe it, it sounds more like that to me. Because I assume if you've been a psychologist for this long, I'm assuming that in your email you would have said, it touched on something familiar to me that I've reviewed a lot in my own therapy and my own countertransference awareness. But you didn't say that. It sounded more like what I would describe as the function of corrective metabolism of feelings that we will do. We will take in, it's not a magical, supernatural thing. It's an attachment-based, evolved process of social feeling, of collective feeling. We do this all the time. When you go to live comedy, you laugh harder. When you go to a funeral, you cry harder. Why? Because there's others. We're not individuals. We are part of a whole. And when you and your client are part of that whole and that feeling is coming up for them, you're invited to metabolize with them. And it's a lot. It was a lot for the client, but you shared it and you metabolized it and you felt it. And it's possible that one valid narrative to put to it is that you don't know where it comes from because it doesn't come from you. It comes from your client. It comes from your client's traumas, and it doesn't have anything to do with your traumas. It's just pure absorption and osmosis and care and being with someone. You're sitting on a bus and someone is jittery next to you and you don't even know the person. It's agitating. You can't get away from that. We are creatures within social fields, within emotional fields, and you had a thing there, and that is a big part of what I believe therapists do for people, is that we metabolize for them. They cannot digest all of the pain, so we digest some of that for them. They give it to us. They see us digesting it, and that digests it. They process as we process. One might even say that some of the time we're doing most of the processing because they just don't have that capacity, and we do. It doesn't mean it's without its problems, and it doesn't mean that we just walk away after the session willy-nilly. It's quite the opposite, in fact. But the calling to become a therapist means, I believe, that we are volunteering to metabolize. We're volunteering to sacrifice ourselves for the greater good, for the client. It brings tears to my eyes thinking about it. It's been well documented, well thought about. It's something that is losing relevance as, I don't know, people lose touch with psychoanalytic philosophy, psychodynamic philosophy. People become more CBT, more professionalized, more medicalized, more agencyized. I don't know. But there was a time when this email would be well understood by 90% of clinicians. 50 years ago, if you read an email like this, everyone would be like, well, yeah, duh. This is what we do all the time. Has no one explained to you about countertransference and transference and corrective experiences and metabolizing and, working with other people's feelings, and also the unnamed, unknowable nature of being with someone emotionally. There's just no way to know, and that sucks that you'll never know, and we can never tell you. All we can say is that after hearing this and discussing it, it's reasonable to conclude that all of that was for the greater good for the client. And you can evaluate it. How does the client feel in the next session? If the client feels awful, then, incorporate that. But in all likelihood, the client feels relieved and lighter and cared for, and you will feel shittier. and it's hard, being a therapist who said it was going to be easy. If you wanted an easy job, then I don't know, what's an easy job out there? I mean, every job has its difficulty, or at least a less emotional job. Become a coder at Microsoft or something. I'm just going to take a guess and say there's less of your personal traumas involved in that. So, this is what you signed up for, and you're accepting this. You're not saying I don't want this, Morgan. You're to me, you're sounding like a true therapist, and you even recognize that. You're just like, this is, I think, one of those moments where I become not only a better therapist, but a better person, a better spouse, And yes. The wisdom and the change and the shift and the help and the meaning and the glory and the vision that you get from shit like this. It's like seeing the Matrix. You can't look back. You can't come back from this. So congratulations. Going on with the email. So my question to you beautiful and lovely humans, what was your most intense clinical moment? How did you feel in the moment? How did you respond? How did you make sense of it later? And how has it changed you as a therapist or person? Bob, what do you think?
Oh, I can't answer this question. Though I want to answer this question, I can't think of what was my most intense clinical moment. One thing that comes to mind, though, is a client that I worked with for a while, a long time ago, who had a awful trauma history, and she and I, we were doing exposure, so she was recounting the story again and again and again of the thing that happened to her, truly awful thing. And I remember she's looking down at the floor, and she's deeply engaged in the memory of the thing, and able to re-experience it, and the idea is as if it's happening right now. And I remember looking down at the floor and crying as I was listening. And I don't know that that's my most intense clinical moment, but it was an intense clinical moment. And I was glad to be there with her.
How was it intense for you?
It was just sad about.
Were you feeling this, like the metabolism and the weight and the difficulty after?
No.
Have you had that experience before?
I have to think about it, and I'm not going to think about it right now because I'll sit here quietly for too long, and it won't work for a podcast. No, I can't say I had that. What I had was deep love for that person, and sadness at the injustice of the thing that she went through and was put through by just an awful, awful fucking human. She's this lovely person we really care about, and I could imagine her as a little tiger. She was a kid then, and I can imagine, because she was kind of a cool adult, so I can imagine her being a really cool kid, and to have that taken from her in the way that it was just made me sad. So I don't know that I would have thought that I was metabolizing trauma, and I don't have the after experience that the person that's writing in has. I do have an intense memory of that, and I have a vivid memory of that, but I don't, and I don't know what it means, but I don't feel as though I carried it beyond that hour. So I don't know.
Yeah. I mean, I've talked about difficult clinical moments before, and the way that I was framing it in the clinical literature sense, so for you, Morgan, when I was doing my research on difficult clinical moments for seasoned therapists, your type of difficult clinical moment would be something that I would hear, but it was more often that when people are asked this question, they would talk about a moment in which they felt threatened or scared or hurt or something like that, like a client that threatened them with a gun or something, or I talked about how I had a client that was just berating, emotionally abusing me, and I was holding on completely fine for 15, 20 minutes. And I remember thinking, I've been a therapist for 20 years, 15 years by this point, and I knew how to handle situations like this, and I didn't take it personally, and I didn't really consider her opinion paramount regarding my self-esteem as a therapist, And so I was holding on, but then something she said, or the critical mass of it or something, and I just had a panic attack in the middle of session and started sweating profusely and couldn't think straight, adrenaline rush, and it was a difficult clinical moment. So I've talked about that before, but your type of difficult clinical moment is a different type, and one that I haven't really talked about, and I'm having trouble thinking of a very specific moment that is I know I've had similar moments like what you're talking about, and I can think of a couple moments that are along these lines in which I at least will interpret my feelings to be a result. Because, when Bob's talking about observing someone describe something as difficult, and it might be hard in the moment, you don't necessarily carry a sense of difficulty or fear later, right? That's what you're saying.
I am saying that,
yeah. And certainly I've had a lot of that, but what you're talking about, Morgan, has more to do with I've really absorbed something, and maybe something's triggered in me, but I don't know, it feels more like there's something there. And actually, when I sort of walk myself through that, fuck yeah, I've had that experience a lot of times. I mean, working with people with personality disorders, it's almost every session when you enter a certain phase, meaning the main phase of therapy, when transference really kicks in. And there's different flavors to it. And the way that you described it, Morgan, is akin, but not exactly. But yeah, so I guess what I would say is that I will narrativize it as, I was really holding on, and that's one of the things that you talk. I'm sort of thinking out loud. Morgan, you talk about how you were really trying to do a good job by your client, and you were really holding on, and you wanted to break down, or you wanted to pull away emotionally, or you wanted to end the session early or something. And that was a theme in my research, is that generally speaking, there was an urge to cut it off somehow, either by changing the subject or pulling back emotionally, or literally by terminating the session, or literally by terminating the client completely, or literally by quitting the session, quitting the profession. I heard all those different examples, and I themed them myself into this effort of getting away. I can't remember exactly how I described it, but an effort to stop what's happening, either by subject or the session or the client or the profession. I had one respondent who was just like, in the moment I thought, I need to quit. I can't handle being a therapist. And again, this is, 20, 30 years into the profession, and you have a difficult kind of critical moment for the first time, just like, I quit. I can't do this. It's, it's natural. Anyway, so so for myself, if I can think about a particular borderline client I worked with in my early career, yeah, that sense of, even before she would show up to session, I would be preparing of okay, I'm going to absorb and hold on, and I'm not going to act impulsively, and I'm not going to act on even what I want or need, because in order to help the client, I have to hold it together, and then afterwards I can relax and let go and be myself. And although I'm genuine and I'm really there for the client, I can't relax. I have to absorb and take it on the chin, so to speak, and take care of myself later. And one way of narrativizing it is that, yeah, I'm absorbing, and I'm putting off my needs for a lot of my needs are being unmet, and that unmetness is building up through the session, and then I can meet it later, And that's hard, for us. And I have to have a compassionate face the whole time. I can't just disappear facially wise. I have to be authentic and real. And so, it's this duality inside of us. And so, you say, how do you respond? How do you make sense of it later? How does it change you as a therapist person? And yeah, it has a profound effect it has had a profound effect on me as a therapist and as a person. And it's interesting to think about me at your phase, Morgan, in the beginning of my career, and how little guidance I had around this, or maybe it's just impossible to really explain or guide or prepare a therapist for something like this. But in my early career, I remember experiencing things and suddenly realizing, oh, that's what they were talking about. I thought I understood what they were talking about, like countertransference or something. And I passed the test, so to speak, but I didn't really get it. And that's another nice thing about experiences like this, is that you suddenly it's almost like you all of a sudden can read a new language when you're reading psychoanalytic literature or Fritz Perls or these kinds of people. When you actually go through these experiences, you're like, oh, or even Irvin Yalom, these kinds of figures, you are now pushed past the threshold into awareness, such that when other people are talking about it, you're like, oh, because it's impossible to describe. And so if you haven't been through it, as one describes this sort of thing, it'll feel like nonsense, or it'll feel confusing, or it'll feel like you're searching. But for people who have been through this kind of thing, you're like, yep, I know what that means. Anyway, let's take a break. We get back. One more email. What do you say?
Yeah.
All right, last email here. Listener Kylie, she says, hi, Dr. Kirk and Bob. Lovely podcast. The podcast is raw, and it's nice to hear what's actually the case. It's raw, and it's nice to hear what's actually the case. Interesting. Listener Kylie says, life hack. I want to share something I learned from a former coworker who was nice to everyone. I worked at a busy gas station. She said she finds just one thing she truly loves about any person. Maybe it's the shirt, their job, their hair. She says it makes it so much easier to be happy and nice. Bob, what do you think about that one?
That's fantastic. It's so easy to find stuff we don't like.
Yeah. Yeah, I also imagine that it just orients the self towards positivity.
Yeah.
Even if you're just like, I like their aura, like it just... we have a hard time holding on to a number of thoughts at one time. And so if you hold on to the positive, then it'll push out any sort of negative going on. I would love to hear about personality. And by the way, my mom is kind of like, I don't know if she uses this kind of technique, but I have heard her say similar things that result in a very noticeable way that she has with people that is extremely gracious to others and giving to others. Anyway. I would love to hear about personality change and other psychological change after concussion, car accidents, or whiplash. I would love to hear about personality change after concussion, car accidents, and whiplash. Have you had any patience with this issue? I was in an incident years ago, and it left me with chronic problems, and I'm getting diagnosed with borderline and OCD now. Bob, what do you think?
I'm so sorry. I don't know anything about brain injury changing personality, so I can't. Unfortunately, I can't really respond to your question. It's an interesting question.
Yeah. There's research in this area, and when we think about brain injury, we typically will hear people talk about cognitive effects like memory deficits or irritability or sleep problems or something like that. These things are easier to measure. They're easier to test. They're easier to talk about. But personality change obviously could happen. If you have brain injury, anything involving the nervous system can experience a difference. But we have a hard enough time measuring personality as it is, let alone demonstrating that the personality was different before and after, and that it's attributed to the brain injury because you can have personality changes for various reasons, so-called personality changes, like your stress is higher in your life and you're just acting in a more stressed out manner. It can bring out other parts of your personality, or who knows. So you won't hear a lot of people talk about it, and you won't see a lot of research around it because it's just hard to lock down. And you'll even hear people say, clinicians or researchers, that it doesn't happen because they either just don't know that it's possible, or they just don't want to face the ambiguity of the question, and so they just deny the whole thing.
That's weird.
That happens all the time in science, particularly when it comes to humans and the brain, because it's just easier that way. And it also has some wisdom to it in that there will be people that will claim things quite adamantly, like, no, Myers-Briggs is a thing, and I know it's a thing. And if you understand the science around Myers-Briggs, you're like, well, there's not really a lot of demonstrable empirical evidence that at least 3 out of the 4 domains have any sort of predictive power. Therefore, it's not really a thing. And so you have this sense of like, unless there's provable, demonstratable data, then it's probably bunk. It's probably bullshit that people make up. So that can be overtly applied to areas that one should know that it has been looked into, but it's hard to lock down. Just because there's lack of evidence doesn't mean that there's a lack of a thing. You know?
Right.
But it also might not be a thing. We just don't know. But it stands to reason that one, like I was talking about maybe in a previous episode about how you could take a med and have increase in compulsion, right? And one could say that's a personality change, right? Your drive, your motivation, what you are interested in, that's a part of personality, right? So that's a personality change with a medication. Well, brain injury can cause all sorts of problems, or all sorts of changes.
Like ex-football players with the constant head injury.
Right.
Yeah.
And you can become depressed.
Yeah.
That's well documented. You can become suicidal. You can even kill yourself, like Junior Seau of the San Diego Chargers. I believe that's his ending of his story. He was a linebacker. I actually worshipped him when I was young because he was Asian Pacific Islander in the NFL, which is kind of weird. And also he was a really famous linebacker that hit hard, and so was I. And so to hear later that he had brain injury and got depressed and then killed himself, and the hypothesis is that it was from traumatic brain injury, which again, we can't know. People get depressed and kill themselves, and you can look at, and what people will say is like, well, when when you look at the brain scans, there's obvious evidence of brain injury and of functional brain differences that are associated with depression or whatever. And the fact is we just can't know. I mean, people can have massive brain injuries and have zero changes in their personality or functioning at all. There are people that will have whole sections of their brain removed, or that will die in a stroke or something, and there will be no difference in anything. Other people can have massive differences and there will be no measurable thing. So, it's just so hard to know. And we can only go off of observation, because we can't take 1,000 people and purposely give 500 of them brain injuries and see the difference. So we have to just watch through observation of large samples after the fact, and there's all these compounding variables, and so we just can't really know. But can someone have traumatic brain injury and any sort of personality change? Yeah, it seems completely likely, and there is some hard science that's demonstrating that. Have I had any patients with this issue? I have had clients who it was a part of the hypothesizing, but it's unknown, and it's also untreatable. You can't reverse that. There's no medication for that really. So it doesn't really matter. So if I had someone with borderline or OCD, and I wondered if it was due to brain injury, that would not be likely for me, by the way. I mean, I can't imagine someone developing borderline from a brain injury, really. But, I guess it's conceivable, at least in part. It wouldn't look the same in all likelihood, but it wouldn't really change my treatment. My treatment would be the same. You know what I mean?
I do.
Yeah.
We're babes in the woods, though, when it comes to the brain.
Yeah. Well, that's it for that episode. Everyone out there, please take care of yourself because
you deserve it.